So thank you, Dr. Thomas, for joining us today for our EASD coverage. May you introduce yourself at first?
So I'm Dr. Nick Thomas. I'm a diabetes consultant based down in Exeter in the UK. And I've got a special interest in type 1 diabetes developing in adults. And I completed my PhD a few years ago in this area, looking at how we can improve classification and better understand the disease in this age group.
Yeah, perfect. So what was your motivation to focus your research on type 1 diabetes in adults?
So when I first got into research, one of the first things that I started looking at was what's the incidence of type 1 diabetes across the spectrum of ages of onset. And traditionally, type 1 diabetes has been thought of as a disease of children. That's what all the textbooks that I grew up reading said. But actually what we showed when we used robust biomarker-based definitions of the disease was that it was as common in adults as it is in children, which was a real eye-opener. We'd always known that type 1 diabetes developed in adults, but we just didn't know how common it was. And if we didn't know that, that meant we must be missing cases. And so that was something that really drove me, because if we're missing cases, we're not giving patients the best treatment. And therefore, this was an opportunity to improve patient care.
Can you say something about the prevalence? How many are misdiagnosed in adulthood?
So there's two directions to look at this. So the first thing is to quantify this. So when we think about misclassification, we think as doctors, oh, we must be doing something wrong. Mm-hmm. But actually the problem is that it's an impossible task. And the reason for that is that although the incidence of type 1 is remarkably stable across the ages, type 2 diabetes dramatically increases with age. So if you develop diabetes as a child, you've got type 1 diabetes till proven otherwise. Over 95% of diabetes will be type 1. Flip to those adults diagnosed over 30, and the reverse is true. The vast majority of those developing diabetes will have type 2 diabetes, and less than 5% will have type 1. So you've suddenly got this really difficult task of trying to differentiate two different diabetes types. And type 2 diabetes can present severely, it can associate with DKA, it can occur in individuals who are slimmer. So it's really difficult to differentiate those cases. So it's absolutely inevitable that some people will get misclassified. And what we've shown, and understandably because type 2 gets more prevalent with age, misclassification or classification becomes harder at increasing age. So with increasing age of onset, misclassification is more common. So if you're diagnosed with, if you've actually got type 1 diabetes as an adult, around 40% of those individuals do not get insulin at diagnosis, and that increases with age. Conversely, there are people thought to have type 1 diabetes, or actually they don't, they have atypical type 2 diabetes. And that's around 1 in 6 adults. Around 1 in 6 adults clinically diagnosed as having type 1 diabetes don't have the disease. And that's important because they could be managed with non-insulin therapies. When we've seen how particularly some of these therapies like SGLT2 inhibitors, GLP-1s are really beneficial for other things like cardio-renal protection. So these patients are missing out on those therapies because they're often not licensed in type 1.
Yes. And you described this diabetes type 1 in adults is often misdiagnosed. Which clinical features make it particularly difficult to distinguish between the two types?
So I think, again, this comes down to probability.
Mm-hmm.
So we typically think of type 2 diabetes as being associated with perhaps higher BMI, older age of onset, and perhaps a more benign presentation. But we know that that's not true in all cases. And certainly when you look across the whole spectrum of people presenting with type 2, there are people who present who are slimmer, who do have DKA, but they have type 2 diabetes. Mm-hmm. And the problem is when type 2 is so much more common than type 1, those rare type 2 cases actually become almost as equal as type 1 diabetes. Mm-hmm. So it's really difficult clinically to differentiate. So the key things as a clinician is to have that awareness that it's hard and that we will not get it right all the time. And the key things is if you think a patient that's got type 1 diabetes is to do biomarkers, so looking at biological markers of the disease, so in this case islet autoantibodies, to confirm your diagnosis. And what we've shown is if you've got a patient who you think's got type 1, and they have antibodies, then they have type 1 diabetes. So you can be confident of that diagnosis. But if they don't, they've got around a 2 in 3 chance of not having type 1 diabetes. And importantly, we've shown that they can safely stop insulin in many cases with close monitoring. Conversely, the other way, patients you think have got type 2 diabetes, the key thing is that the disease will drive the treatment. So the problem, and we heard from Professor Hattersley around Theresa May, who was the former UK Prime Minister, who was misdiagnosed with type 2 diabetes but had type 1 age 50, was that the disease will not get better on type 2 therapies because patients need insulin. Mm-hmm. And so if you've got patients that are rapidly progressing to insulin, we've shown that that is a key determinant of consideration of does this patient actually have type 1? And again, antibodies in that context is someone who's rapidly progressing to insulin within 3 years, who you think has got type 2 diabetes, do islet antibodies. And if they've got positive antibodies, they have type 1 diabetes. Mm-hmm. And so that's the kind of message is we will not get it right the whole time, but to be curious as a clinician and to consider that diagnosis and where things don't quite add up, to remain kind of agnostic, if you will, particularly in those you think have got type 1 but are antibody negative, and just keep questioning that diagnosis moving forward, because we can measure things like C-peptide in long durations or over 3 years duration diabetes. And if you've got someone who's insulin treated with a high C-peptide, so say over 600 picomoles, after 3 years duration, they probably don't have type 1 and will probably benefit from non-insulin therapies, either stopping the insulin or alongside it.
Sounds good. What do you think? How does the frequent misdiagnosis of adult onset diabetes type 1 affect research into disease progression and also to therapy?
So this is a really important question. Right? So we have traditionally almost siloed those two areas of research. You've got how do we improve clinical care, which is vital for the patients in front of us. But all the information that guides us doing that is from the research field. And you can imagine that if we're studying cohorts with type 1 diabetes where 1 in 6 of them doesn't have the disease, but we're not studying the true phenotype. Mm-hmm. And this has led to issues, I think, with how we perceive adult onset type 1. So it's often told to me, it's a benign disease. It doesn't progress rapidly. These patients often, have a slow requirement for insulin. Well, that will be true if you've got lots of people that have actually got type 2 diabetes. And what we've shown is that if you really carefully study true type 1 using biomarker-based definitions, and actually type 1 diabetes in adults looks very similar to type 1 diabetes developing in children. There are subtle differences, but it is far more similar than it is different, including genetics, including rates of islet autoantibodies, and including that loss of C-peptide and rapid requirement of insulin. And so it's critical that when we're thinking about studying type 1 in adults, if we really want to understand the disease, we need to use robust definitions.
And what concrete recommendations would you give diabetologists to avoid misdiagnosis and ensure the optimal patient care?
So it's vital to remember that this is hard and that we have to use our clinical acumen and that we will never get it right. But it's always considering the possibility that this patient, who we think has got type 1 diabetes, might not. And certainly if they're antibody negative, just keeping that in the back of your mind and keep tracking their C-peptide and thinking about the possibility that actually they may benefit from non-insulin therapies. Conversely, as I said, if you've got a patient with type 2 diabetes who's rapidly progressing and requiring insulin, just have that possibility that they can have type 1 diabetes. Because remembering that of all the patients that have type 1, 40% of them in adulthood will not get insulin at diagnosis. And just again, remaining curious and thinking, well, could this be type 1 diabetes? And islet autoantibodies are relatively cheap. They cost around €30 to measure. So there's no reason in my mind that we shouldn't be then considering that diagnosis. If you've got an individual that is progressing rapidly with a diagnosis of type 2, who's then got antibodies, they have type 1 diabetes and should be treated as such.
Yeah. And do you think there's something on the horizon to in future distinguish more or better between these two types?
So the key thing here is clinicians considering whether an individual has type 1 diabetes. So I've said that if we clinically think they have type 1, then we should be measuring antibodies. But what I think might look like type 1 diabetes, another clinician might not think looks like type 1 diabetes. And what I think might be type 2, another clinician might not think. So what we need to do is actually quantify, because we're all looking at the same patients. We're all measuring in our own minds those different features at presentation, whether it's what was their HbA1c at presentation, were they symptomatic, what's their BMI, how old are they, what's their family history. And it's impossible really to collate all that information, particularly when you're only seeing across a career tens, hundreds of patients presenting, to really accurately have a really good feel. What we need to do is collate all that information together into models. So we need to have probability models, which are being developed by my colleague, Professor Jones in Exeter, to say, actually, can we quantify that clinical feeling of, I think this patient is more likely to have type 1, type 2, into an actual predictive outcome. And then that can then be combined with autoantibodies, potentially genetics, as that becomes more accessible, to try and improve in a kind of logical, data-driven way the likelihood that that patient has type 1 or type 2 diabetes.
Okay. Thank you very much for taking the time to speak with us about this interesting topic, and I'm looking forward to read more of you.
Pleasure. Thank you very much for your time.